One of my great heroes of implantology is Hilt Tatum, and I was fortunate enough to have been taught by him, um, and the eminent American grandfather of implantology, Hilt Tatum. And he was aware of this problem many, many years ago, and he personally measured 300 edentulous ridges in the lateral incisor region, upper jaw, and over 70% were less than 3.5 millimeters wide. As you know, implants start at about 3.5 millimeters in width, so we've really got a challenge here. We've got a dilemma. The bone is thin, but we'd like to place implants. And what he did some 30 years ago was quite revolutionary and innovative. He devised a process of ridge expansion. So he developed a series of instruments, starting actually with a scalpel blade, which you don't see here, and went to the tip of the ridge, and then using a mallet, went and inserted an instrument into the ridge, not with a view to splitting it, but with a view to expanding it. So it was a rather gradual increase in size of instrument, and he tapped in the instruments and gradually opened up and expanded the bone. And this was really a stroke of genius from Hilt Tatum, and he then was able to place an implant in that thin ridge that we talked about earlier. Other options for resolved ridges, and we're very often dealing with width, is either outright rejection, and this is what we hear from our patients, is that sometimes if it's just too difficult, they don't want to do it. So either the dentist will reject it or the patient will reject it because they don't want to have augmentation. But as we know, we have various materials now, synthetic, bovine, and allograft materials, where we can add to the ridge and augment it. They can be particulate, and of course we can use a graft from the patient themselves, a block graft in some cases. Here in the UK, I think this is a fairly international norm. It is it's said to be 50% of all implants placed involve some form of augmentation. 50%, quite a high number.